Hi, everyone. We're just so delighted to welcome Dr. Sarah Orather to our March Annie Research Forum. Dr. Orather is an assistant professor at the Goldfarb School of Nursing at Barnes Jewish College in Missouri. And I will leave it to you to introduce yourself further. Dr. Orather, welcome.
Well, thank you. Thank you so much for having me. Oh gosh, I just clicked off my screen. So, as I said, my name is Sarah Other. I am an assistant professor at Goldfarb School of Nursing. 5 days ago, I became the program, well, probably 7 days ago, I became the program lead for the school nurses program. So I'm really, really excited to move forward with the school nurses program. If any of you guys have a background in school nursing or want to be a guest lecturer for some school nursing classes, I would love to invite you. And I'm really excited about really weaving in environmental health and exposure science into their courses. I'm going to go ahead and share my screen because it'll take me a second here. Let's see. Okay. So let's see here. There we go. From the start. Okay. So as I said, my name is Sarah Other. Turn off the closed captioning. And today we're going to be talking about pediatric discharge diagnoses
We're
associated.
we're
Can you
the
hear
we're
me?
I just want to check to make sure that you know that the screen your slides are not shared right now.
Oh, they're not? Okay, let me see.
I
Can you
know
see
that
it now?
I know that you did it early. No.
Oh, okay, well, let's see it. Okay, we just did it. So,
We just practiced.
yeah, I know we literally just practiced. So let me see if that works. Can you see them now?
Yeah, perfect.
Yay, okay, I'm great. Technology is not my strong point. I really like people and computers aren't my thing. So today we're going to be talking about characterizing pediatric discharge diagnoses associated with daily extreme heat exposure in the Midwest United States. This is a retrospective case crossover study. I know it seems like a lot, and we're going to break it down throughout this presentation. Just as a caveat, I did give this presentation today at a federally funded healthcare center in a rural area in Missouri. So I kind of interchange sometimes extreme weather and climate change together, just because different people I speak with, it just translates better. It's easier for them to understand. So if that's offensive to anybody, just speak up, and I'm happy to change my language as we go, okay? So my collaborators were from St. Louis University, Washington University, and Goldfarb School of Nursing. And I'll go into this a little bit more as we go, but I just wanted to take a second to recognize them. Funding for this project came from St. Louis University, Washington University, and I'm a charter fellow with Emory University, and so some of the funding's from NIEHS. So the first objective of this presentation is to understand the impact of extreme heat on pediatric health. When we say extreme heat, we're not talking about is it 100 degrees Monday, Tuesday, Wednesday, Thursday, Friday. We're talking about extreme temperature changes. Do you wake up one day and it's 60 degrees, and then the next day is it 90 degrees, and then does it drop down the next day to 70 degrees? So when we say extreme heat, we're not talking about 100 degrees every day. It's the extreme temperature changes we experience day to day. And interestingly, last week we just experienced those temperature changes in Missouri. One day it was like 54 degrees. The next day it was like 85 degrees, and it dropped down to like 40 degrees. So we've been experiencing those extreme temperature changes right here in Missouri just this past week. We're also going to describe the relationship between daily extreme heat exposure and pediatric discharge diagnoses across various healthcare settings, including urgent care settings, emergency departments, and inpatient hospitalizations. We're going to identify specific age groups, sexes, races, socioeconomic statuses that are more vulnerable to the health effects of extreme heat. Just as a quick outline for this presentation, we're going to do an introduction, background, aims, methods, results, discussion. Then we'll talk about some clinical implications, knowledge gaps, limitations, which there are a few, and some key takeaways. I'm a very laid back speaker, so if you want to jump in and ask some questions as we go, please feel free. But please know, yes, we will be getting to the limitations. If you're like, oh, is this a limitation of the study as we're going? I'll probably mention it at the end, but if I don't mention it, I really hope you feel free to just speak up, talk about this. This is meant to be a discussion. Okay, So I'm sure most of you on this call are familiar with this slide and know that weather impacts a wide range of healthcare outcomes. And I love this slide from the CDC because I think it does a really great job of showing how weather impacts our health. So we know that air pollution may trigger asthma. We know as spring times become earlier and falls become later, that we're seeing changes in vector ecology. So as animal migration patterns change, along with these weather changes, we're seeing Lyme disease and alpha-gal pop up in places that we've never seen before. We're also seeing increased allergens because of the earlier springs and later falls because vegetation's changing. We're seeing that in different places we haven't seen before. I'm going to have to move this real quick. Okay, so extreme weather. In 2021, the U.S. spent over $820 billion on health-related climate events. That's kind of what really got me interested in this topic. The U.S. experienced record-breaking high temperatures in 2023, disproportionately affecting vulnerable groups. And that's where I really latched onto this heat problem in children. And I picked children because children are uniquely vulnerable to extreme heat. So children are uniquely vulnerable due to their developing thermoregulatory systems and higher metabolic rates. And there's a lack of research on pediatric discharge diagnoses related to healthcare utilization associated with heat metrics in the US, but especially in the Midwestern United States. So there is some research on pediatric discharge diagnoses on the East Coast and West Coast. However, there is a lack of research in the Midwest, and that's why I specifically focused on the Midwest because I live in the Midwest. So a lot of the research I'm going to be referencing, and I have all the references at the end of this presentation, is based on the research that's been done on the East Coast and West Coast. There are limited empirical studies on factors that could influence vulnerability to heat, such as neighborhood, socioeconomic status, racial or ethnic background, and chronic health conditions. Primary objective of this study was to explore the correlation between daily extreme heat exposure and pediatric discharge diagnosis in various healthcare settings. And I will preface this with correlation doesn't exactly prove causation, but we have to start somewhere, and this is really a preliminary study. The secondary objective of the study was to examine how patient demographics and comorbidities may exacerbate health effects of extreme heat exposure on children. This was a time-stratified case crossover study, and I was looking at big data. So St. Louis University is part of SSM Healthcare System, and SSM Healthcare System shares their records, has big data in their virtual data warehouse, and SSM covers Missouri, Wisconsin, Oklahoma, and Southern Illinois. And just to, preface this, we're looking at mostly cases of pediatric discharge diagnosis for patients that do have insurance. So I will say that. And we looked at 12 individual morbidities of interest, and we chose May to September 2017 to 2022. The specific conditions of the specific comorbidities were asthma, cardiovascular disease, dehydration, diabetes, etc. And this, again, was based on previous studies in the literature. Inclusion criteria for the study included pediatric patients birth to 18 years old. We used the 12 morbidities of interest. We looked at the ICD codes. We looked at urgent care visits, emergency department visits, and inpatient hospitalizations, again, between May and September 2017 to 2022. The exclusion criteria were obviously patients greater than 18 years old on relevant case days and patients not visiting urgent care, emergency department, or inpatient hospitalizations for the conditions of interest. Exposure measurement. So St. Louis University has a geospatial center. I worked with researchers at the geospatial center, and we decided to gather mean daily temperature at the 5-digit zip code level in the Midwest with the Prisma Climate Group at Oregon State University. Again, we chose mean daily temperature data because that's what's been used in previous studies. The definition of extreme heat was also based on previous studies. So we looked at daily temperature greater than the 90th percentile for the month. Demographics were broken down as follows. So age, we looked at children under 1 year old. We looked at preschool children, basically 1 to 4 years old. Then we kind of broke it into school age children, 5 to 11 years old, and then more kind of preteens and teens, 12 to 18 years old. And again, that's how it was broken down in the literature most commonly. This is where it was kind of difficult. So we looked at white, black, and then we had a category for other race. It felt very uncomfortable labeling it other, but we had a very, very small segment of the population that fell into other race. That's really what the statistician recommended. If I could go back and do it again, I would not use that category other, but that's what the research group agreed on at the time. Sex was male and female. We looked at neighborhood socioeconomic status, which is a previously validated method in the literature. So in this study, we had approximately 500,000 patients, and we found significant associations for discharge diagnoses, dehydration, general symptoms, heat-related illness, and infections. And this is our regression model results. So interestingly, there were no significant increases in discharge diagnoses for respiratory diseases. And in scoping reviews we had done, especially with cases on the East and West Coast, there was a significant increase in respiratory diseases as well in some studies. This difference may be significant in understanding how different regions react to heat. And I'm sure, as most of you on this call know, geographic areas might lack factors contributing to respiratory problems, such as high allergens during that time of year or urban heat islands. So again, it's very important to continue to monitor these trends over time in a more extended period of time and across different regions. It's really essential to understand broader patterns and potentially delayed impacts from extreme heat as well. And again, I think as we are talking about climate change, it's really important to consider how things are done at the local level. It's great to have the big data at the national level, but the way the East Coast does stuff and the way the West Coast does stuff and the way rural people living in rural Missouri react to heat is very different. So again, trying to bring our recommendations down to the local level is something I've really learned through developing this study. The overall cohort for the study was primarily white ethnicity, and children were primarily over the age of 4 and high socioeconomic status. So what do we find? Our stratified analysis for age-specific associations. Children under 1 year old were 31% less likely to visit various healthcare settings for all causes during extreme heat exposures. Children aged 1 to 4 years old were 8% more likely to seek care during extreme heat exposure. For the stratified analysis for sex, male patients who were exposed to extreme heat had an increased odds for visits for dehydration. No association was found in female patients. Patients classified as another race who were exposed to extreme heat did have a slightly elevated odds of visits for or discharges for respiratory conditions. No associations were found in Black or white patients. Stratified effects for extreme heat on morbidities of interest by neighborhood socioeconomic status. There was a statistically significant increase in visits for general symptoms and injuries in low socioeconomic areas exposed to extreme heat. Patients in high socioeconomic neighborhoods did not show significant associations between extreme heat exposure and that shouldn't say doctor's visits, but visits for general symptoms. So what are the knowledge gaps? Where are we going with this? We do need more longitudinal studies. This is a brief snapshot of the Midwest, but we do need more longitudinal studies. And the study did not take into account individual behaviors. We were looking at electronic health records. So this did not take into account time spent outdoors, local environmental features like urban heat islands, and other health-related heat issues. Demographic groups are more vulnerable to specific health issues during extreme heat. We really need to look at the different demographic groups that are more vulnerable and do more research on that. More data on the symptoms and conditions that lead to healthcare visits during extreme heat would help to better understand the health impacts of extreme heat exposure. And comparing these findings with populations in different climate zones could provide more insight into tailoring climate adaptation strategies to different environments. So what are the clinical implications? Staffing ratios are definitely something we want to consider during extreme heat periods. We also can consider educational and preventative measures that are targeted across different age groups. So how you would educate the parent who has an infant might look different than the parent who has a child age 1 to 4, or basically in preschool during an extreme heat event, which might be different than educating a parent with a school-age child or a teenager. Let's think about why. Infants, you're carrying the infant more, you're carrying infants more when they're smaller. Children ages 1 to 4, they're beginning to learn to walk. They're still learning to communicate with you. So again, our educational interventions and measures really probably need to be different for parents for different age groups. We also may consider sex-specific strategies in hydration and cooling efforts during heat waves, especially when we look at sports. Again, males showed an increased odds for visits for dehydration during extreme heat. Low socioeconomic neighborhoods, we need to probably be more proactive with community health initiatives and resource allocation to these areas during extreme heat events. Limitations, generalizability, obviously. This data was from the Midwest, parts of the Midwest, not even the whole Midwest. So SSM system in Missouri, Wisconsin, Oklahoma, and Southern Illinois, which definitely limits the generalizability of these results. This electronic health records, again, they do not take into account individual behavior patterns, such as time spent outdoors. We used a very broad definition of extreme heat exposure based on the literature. But again, this does not take into account critical factors like what was the nighttime temperature during this, and were there delayed reactions to the extreme heat? And the study was probably underpowered to detect significant associations, such maybe as children with diabetes. So what are some key takeaways? We found significant associations with dehydration, general symptoms, heat-related illness, and infections. The impact of extreme heat exposure varied across various demographics, with vulnerable groups including children, ages 1 to 4, males, and individuals from low socioeconomic areas. That's basically the end of my presentation. Again, thank you for having me, and I'm going to stop sharing. And I'm looking forward to some discussion about this. I would love to know your questions.